Okay. So we'll be talking when the bone marrow fails. It's a big problem, a big problem. So, but like a physician working in the emergency, you can only suspect bone marrow has failed with your full blood count. So when you see a full blood count and there's anemia, there's thrombocytopenia, there could be many causes of that. So it is for the hematologist. Sorry. It is for the hematologist to decipher what we are dealing with so that we'll give appropriate treatment. As I was coming for this lecture, I just thought of two patients we saw on Monday in the clinic with anemia and thrombocytopenia. So I printed the full blood count for you to share with you. I will share it with you, just go through it. The one of them, the hemoglobin is 5.5, the hematocrit is 17.3. Yeah, and then platelet is 94,000. The other one, hemoglobin is 3.9. The hematocrit is 11.8%. And then the platelet is 78,000. So you can imagine the challenge. So when we come across this kind of results, we want to do a bone marrow aspiration to find out, because there are many causes, many things can be responsible for this. And this patient has, the two of them have normal WBC count, normal WBC count. And that is what is called bicytopenia, that is affecting just two cell line and not pan. When is everything together is pan. Unicytopenia, just one. But if you want to make a diagnosis of plastic anemia, you need at least two cell lines that are affected, apart from the marrow cellularity. We'll be talking about marrow cellularity, like you are aware, bone marrow failure syndrome can be inherited or acquired. So the inherited those syndromes that are associated with most of them, apart from the bone marrow failure, they also have skin issue, they have nail issue, they have skeletal issue, they have names. You may not be able to diagnose in Nigeria because you require cytogenetic study and some molecular study. You have some that affect all the cell line, like Fanconi anemia. They are inherited. I'm talking about the inherited type now. The Fanconi anemia, dyskeratosis congenita. You could have reticular agenesis. They affect all this. You have them in the slide. Reticular agenesis and so on and so forth. And the some affect only a single line. It could be congenital neutropenia, just is a neutrophil that are affected. Some could be anemia alone, Blackman diamond anemia. Some could be Schwarz diamond anemia, and some could be platelets. So they are all inherited, and most of the time, if you have bone marrow failure from birth, the chances of survival to adult to this is very slim. It's slim. So, so these are the various forms of bone marrow. Okay, let me. These are the inherited form of bone marrow syndrome. So this Fanconi anemia, this keratosis congenita, they are all syndromes that will affect all the cell lines. They are usually due to cytogenetic abnormality, DNA mutation in utero from birth, and then we'll have pancytopenia, like 5-day-old baby having anemia, thrombocytopenia, leukopenia. Then you start suspecting some of these syndromes. This is another one, person syndromes. These are all that inherited that affect only maybe just the cell line, like congenital neutropenia, called Costman syndrome. And then this is the Okay, diamond black one anemia is just the anemia that. So there are other, that affect only the single cell line. So, depending on what you have, you can always. So these are other ones. Go back. Okay, this just the platelets, and this is also platelets. We don't want to dwell too much on this because you are not likely to come across them in your practice in the country. So, but this is about congenital, I mean Fanconi anemia. And this individual have accelerated. I want to explain the slide so that it will be clearer when you are reading it. Telomere shortening. You know what telomere is? What is it? Telomere. 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 They are the tip of the chromosome. The tip of, so as you age, the telomere shortens, and that is what is responsible for aging. As you age, the tip of the chromosomes has what is called the telomere. So there is an accelerated telomere shortening that the person will age, faster than normal. So that's the problem with. What about the G2, prolonged G2? What G2 in cell cycle? You have the interphase and mitosis. So there is G1, there is G2. So the G2 is prolonged before it gets to mitosis, and there is increased apoptosis. So that you know what apoptosis is cell death. So the individual with Fanconi anemia is not likely to live long, and characterized as hypersensitivity to DNA cross-linking agents. These agents, they are chemicals. Can cause DNA mutation. So there are various type of genes for Fanconi anemia, and these are the genes. These are other. So clinically, patient will present with café au lait. We know what café au lait is. Café au lait, they are skin lesion, hypersegmented skin lesion. So uh, bone marrow failure syndrome. Apart from bone marrow failure syndrome, we have café au lait, and then skeletal abnormality, genital urinary abnormality, GIT abnormality. So the person is not likely to live with all these combinations. So even the bone marrow failure syndrome alone is enough to kill the person. Like I said, just for your information, you are not likely to. So I want to share this because I want to go into a plastic anemia, which is what we see most of the time. So this I've picked on just two of each one: Trashman's Diamond syndrome and this Diamond Blackman anemia. Okay, they are all inherited. So we'll talk about the plastic, which is acquired the plastic anemia. So I will share this. Just send it, read, go through it, and then circulate it amongst yourself. So how can I play the video? So I want to, because to make a diagnosis, we need to do a bone marrow. So I just want you to watch the how bone marrow procedure is done. Okay, is that the one I picked? Are you sure? The procedure starts by finding the correct level. Okay, this you pass the needle round. This is the needle we use for bone marrow aspiration. Hold on. This is the needle we use. This is for adults. We also use bone marrow. We use this for aspiration and biopsy. Okay, the difference between aspiration and biopsy is that aspiration, you aspirate the content of the bone marrow, and then you make a smear. You know how to make a smear, blood film. You wash that and then stain, and then if you have a trained eye, then you look at it and make a diagnosis. But at the same at times you will do this and you won't be able to make any diagnosis. So we also do a biopsy with this. We'll, put this inside. We'll see the video. Put this inside the marrow, and then take a little chunk of the bone, okay, and push it out with this stylus, or this. We push the bone, so we put it inside formalin, and then it is decalcified in pathology. Is the pathologist that reports bone marrow biopsy. So this is for adults. We have various sizes for children, for adolescents, but this is very good. This is what we Jamshidi needle. It's called Jamshidi needle. So you can pass it round. Jamshidi. Before, when I was in training, we used autoclavable. Metal needle. We use and then autoclave and then reuse. But that is no longer, because of the risk of infection. So this is a disposable needle. So the cost of marrow in hematology is like 30K, 30,000. So I just want you to see, and then maybe we should play the video and see how it is done. Okay, before then, so okay, hold on. So for bone marrow needle, we use either the anterior superior iliac spine, okay, or posterior superior iliac spine, or we use the tibia in children. We use tibia bone, the middle malleoli of the leg, of the bone, tibia bone, middle malleoli. And then if you are bold, you use the sternum. But if you put your needle into the heart of the person, you are on your own. So you can do. If I will pass it, I'll play the video and watch the video how it's done.
The procedure starts by finding the correct level for the biopsy. The biopsies are taken from the upper iliac crest with access via the ventral spine. The midline of the spinous process is identified, and the iliac crest is located by palpation. When the correct point is found, the puncture point is marked using a straw. This is to avoid losing the marking after washing. The area around the puncture point is washed with colored chlorhexidine. The procedure is carried out aseptically, but without sterile drapes. The area around the puncture point must remain sterile during the whole procedure. Correct placement of local anesthesia is important for how the patient experiences the procedure. 10 milliliters of xylocaine with 10 milligrams per milliliter of adrenaline is normally used.
So we use xylocaine, local anesthetic. It's not done under GA, except you want to do bone marrow aspiration. The quantity we aspirate for bone marrow transplant, is so much that you can't do it under local. So we just get 5 minutes xylocaine, infiltrate the area we want to use before we insert the big needle. So you allow the effect of xylocaine to work before you just like 3 minutes, 4 minutes. You inject it while you are getting your sterile glove ready. Okay, that's the needle. So you land on the bone, and then you rotate. Okay. Okay, you can see the aspirates.
3 small and 7 larger smears are placed on slides. The slides are tilted, and the blood, which collects in the lower edge of the smear, is removed before it coagulates. We then use
so that's the aspirates. So that's the smear. So that's containing the aspirates.
A new aspiration needle is used for aspiration.
So which landmark is he using here? Is it which of the bone? Which area? Posterior superior iliac spine.
Milliliters is aspirated with the syringe.
So when you insert the needle, you now use like 20 ml syringe or to aspirate the content or 10 ml syringe.
Finally, a punch biopsy is taken. A disposable needle is used. The needle is inserted in the same puncture wound.
So you're on the bone. It's on the bone.
Needle is rotated with constant
So you now squeeze and squeeze, rotate it until
the needle does not slide into an area
until
anesthetized.
you get into the marrow. And when you are in the marrow, you now aspirate.
The rotation of the needle is continued until
Hello.
it is penetrated deep enough into the bone.
Wa alaikum salam.
The spoon is inserted into the needle.
Ẹ jọ̀ọ́, ta ló ń sọ̀rọ̀ mo wà ní lecture? Ta ló ń sọ̀rọ̀?
The biopsy needle is rotated without pressure in both
Ah,
directions.
okay, mo wà ní lecture báyìí, mo wà ní lecture. Ẹ jẹ́ ká sọ̀rọ̀ later, ẹ jẹ́ ká sọ̀rọ̀ later.
The needle to its spoon in biopsy is pulled out.
So that's they rotate the needle. Where is my needle? Okay, just pass it round. Okay, that's the biopsy. That's the biopsy.
The incision is closed with strips and covered with an adhesive bandage.
Yeah. Come, I can't hear you. I can't hear you. I can't hear you. Okay. Eh?
Does not really work on some patients. It's not that doing surgery. So is there like an option, like an alternative in case local anesthesia?
No, increase the volume. If it doesn't work, it's unfortunate. You can't use GA for this, or you can't use epidural. It has to be local. So,
There was a man that
well, it's unfortunate. I can't hear you. It's just going to be pain. Just don't talk about it. Yes, now. So we have to bear it. Yeah, you have to bear it. Don't let this thing fall off. So, so once you get the aspirate, you make a smear and you stain, and then we look at under the microscope to make a diagnosis. So that's what we do in hematology when we are doing bone marrow aspiration. So, and that one, if you are trained, you'll be able to make a diagnosis that it is a plastic anemia, it is not a plastic anemia, it is AL. There are so many. Have you passed around the results? Have you seen the results? So the results, you'll be able to link a diagnosis with the results. So in your exam, we can give you this kind of results and ask you to give us a diagnosis or differential diagnosis so that you'll be able to interpret it. But what is obvious in that result is the anemia, and then there is thrombocytopenia. But WBC is normal, and so it's even high some. So, but one has a normal WBC. So how do you make a diagnosis of a plastic anemia? So, okay, I must mention, you have to listen to this, that in the bone marrow, you have the fats and then the hemopoietic cells. The hemopoietic cells are the erythropoietic cells, lymphopoietic cells, myelopoietic cells, and thrombopoietic cells. Okay? Okay, so how we assess it is your age in years minus, 100 minus age in year, your age in years. 100 minus should be the cellularity, the cellular content. 100 minus your age in years is the cellular content. Okay? You should know that. So which Which of these will have a higher cellular content? A 5-year-old and a 70-year-old. 5-year-old. So, okay. That's I want you to take that. So if you now have you have a patient that is, for example, 40-year-old, and you expect a cellular content of what? 60% of the marrow, and then you are seeing 10% and seeing 90% of fat, and then you have that kind of results. No anemia and then thrombocytosis. What's the implication? The marrow has been replaced by fat. There is no cellular content. There is no cell to produce red cell, to produce white cell. So that's how we determine cellularity. 100. So you need the age of the person you are dealing with to determine the cellular content. Okay? So, but in aplastic anemia, the marrow has been replaced with fats. The marrow has been replaced with fat. If you have fat everywhere, where will the blood come from? Where will the red cell come from? Where will the white cell come from? Where will the platelet come from? If they have been replaced with fat, okay? So that is the problem with a plastic anemia. Okay, so and it's very easy to make a diagnosis, very easy. Just do a marrow and then you look at the cellularity, it will be hypocellular, we call it hypocellular, or the biopsy is best diagnosed with a biopsy, histology and a biopsy. The histopathologist will look at it. I'm going to show you how it looks, the cellularity, and then we'll be able to, so it's very easy to diagnose. So, and there are definitions. A plastic anemia requires at least two of the following. In addition to hypocellular marrow, there must be hypocellularity in the marrow, and then there must be anemia, hemoglobin less than 10 gram per dl, platelet less than 100,000, and then neutrophil. Absolute, you know how to do absolute neutrophil count? The absolute neutrophil count, absolute lymphocyte count. Do you have idea how it is done? Okay, is the neutrophil percentage times the total WBC. The whatever you get, if you check that, do you have neutrophil percentage there? Do you have neutrophil percentage in the result you are taking around? 50%. 50% times the total WBC. What is it? What is the total WBC? Just quick calculation. So you do it. So 50%, that's 50 over 100 times 4 point something. That's the, if you want to do absolute lymphocyte count, that's what you do too. Absolute eosinophil count, that's what you do. Absolute basophil count. Your machine, your systems, we have two types of machine, automated machine. There's what is called a 3-part differential, and there's what is called a white part differential. I hope you are listening. So the 3-part differential will give you the white cell differential, just the neutrophils, the lymphocytes and others mixed. That is the 3 parts. What are the others mixed? Apart from lymphocyte and neutrophil, eosinophil, basophil, monocyte mixed. So that is a 3 parts. It's called 3 parts machine. We also have 5-part machine that will give you the percentages of all the various differential, the basophil, the lymphocytes, monocytes, eosinophils, and then the absolute count. The absolute count. So that's the 5-part. So this is, so to consider a diagnosis of a plastic anemia, you need the marrow to be hypocellular. Okay, apart from being hypocellular, then you need two of those. There must be bicytopenia. Bicytopenia. Okay, so that result we are taking around, is just suspicious of a plastic anemia, can you confirm, how do you confirm it's a plastic anemia? You just seek that kind of a result. How do you confirm that it's a plastic you are dealing with? No, there is bicycle, yes, hypocellularity. You must do a marrow. You must do a marrow. So if you do a marrow, because like I said, many clinical conditions can present that way. So if there is no hypocellularity, then you rule out a plastic anemia. Are we together? So there must be hypocellularity, marrow hypocellularity. Okay. So this is, yeah, it is classified into very severe, severe, and non-severe. Plastic anemia can be classified into very severe, severe, and non-severe. Number one that must be present in a plastic anemia is that hypocellularity. And you cannot determine hypocellularity from peripheral. Can you do that? You have to do a marrow. You must do a marrow and then look at the cell compared with the age of the person. So it's 100 minus age in years. Okay? So if you are 23 years, that's the average age for this class, 23, 24. Your, except those that did the first degree, but for UTME, they should be 22, 23, 24. So your cellularity, if I do a marrow for you, your cellularity should be like 76% if you are 24, or if you are 25, should be 75%. Okay, so just an estimate that if you look at the field, 75% of the field, has hematopoietic cells, and 25% of the field has fat cells. So just an estimate, not that you'll be counting 1, 2, 3 like that. So that's we do when we are reporting bone marrow, we talk about cellularity first, whether it's normocellular, hypocellular, or hypercellular. What will make marrow to be hypercellular? Leukemia. You are right. So marrow, if you look at it, and then a 30-year-old man with a cellularity of 100%. Yeah, we see all sorts. Cellularity of 100%, no fat cell at all. So you start suspect, and then you now look at the morphology of those cells. When you look at the morphology of, so which cells is making the marrow to be hypercellular? Is it the lymphoid cell? Is it a myeloid cell? So you now use that to make a diagnosis. Oh, if it is predominantly lymphoid, it's likely to be acute lymphoblastic leukemia. So if it is a myeloid cells, it is acute myeloblastic leukemia. That is, if they are blast cells, they are predominantly blast cells. We know how blast cells look like. But if they are matured cells, it cannot be acute. Matured cells are matured chronic cells. Okay. So that's how we make our diagnosis. I hope we are on the same page. So for severe aplastic anemia, bone marrow hypocellularity should be less than 25% of the expected. Okay. So your cellularity, you are 25 years, your cellularity is 75%, and then you have less than 25% of 75. What's the meaning of that? If you have 50% of 75, that's like 37.5. You are seeing cellularity of 37.5, abi? But if it's 25%, you are seeing like 40 something percent of your expected cellularity. So that is or if it is between 25 to 50% cellularity, then you can estimated hematopoietic cell is less than 30%. You can say, okay, this is likely to be a plastic. I'm on the same page with you. Yeah? No. Okay. You are 25-year-old you've done a marrow, you are expecting cellularity of what? 75. But if you have less than 25% of that 75, then it will fit in into the diagnosis of aplastic anemia. So what is 25% of 75? So I said if it is 50% of 75, that's half of 75. That would be 37. So what's 25%? Less than 25% will be what? Will be high now. Will it not be high? Will it be high or low? It's less than 25 PR, it will be low. So that would be 18 point. So if you see cellularity of 18 point something, that means it fits into. But if it's between 25 and 50% cellularity expected for that age, then you must look out for the hemopoietic cells, whether it is less than 30% expected. Hemopoietic cells will be 75%. So if it's less than 30%, then you can fit in into diagnosis of aplastic anemia. Cellularity, like I said, you can use the cellular content or the fat to determine the fat content. If the fat is taking up everything, apart from that, you now use your peripheral blood film or your full blood count. In addition to that, your absolute neutrophil count should be less than 0.5 times 10 raised to power 9 per liter. Well, so how do we do absolute neutrophil count? The neutrophil percentage. Your machine can determine that for you. Your machine, if it is, it will give you in percentages and then give you the absolute count. So even if you look at the machine, so the absolute, so if it is severe, you have established hypocellularity, okay, and then you now have platelet count less than 20,000, or neutrophil, okay, or reticulocytes. Some machine can count reticulocytes less than 20,000, and then you can fit in into a severe aplastic anemia. But everything stands except the absolute neutrophil count for very severe. In very severe, the absolute neutrophil count, instead of 0.5 times 10 raised to power 9, for very severe, it will be 0.2 times 10 raised to power 9. Very severe aplastic anemia. So you can categorize your aplastic anemia into severe, very severe, or non-severe. Non-severe is when everything stands, platelet is less than 100,000, hemoglobin is less than 10 gram per dl, and then the neutrophil is just above 500, above 0.5. 0.5 can also be 500. 0.2 can also be 200, depending on the unit. Okay? So if it's between 500 to 1,500, then it can be non-severe. But there must be hypocellularity. Are we on the same page? Okay. So these are the causes of aplastic anemia. We see a lot of cases. I won't say a lot, maybe average of maybe 2 or 3 per month of aplastic anemia in the clinic. So we can notice that their eyes. That's what I used to remind myself. Inevitable, idiosyncratic, inherited, industrial, immune. There are about 5 eyes. So you use that to